Now we are moving to our second session on non-invasive ventilation. I would like to introduce Dr. Bhaginda Gunawardana, consultant emergency physician, currently attached to District General Hospital, Mathura, to present the lecture. Over to you, sir.
Good morning, everyone. Before moving into the proper lecture topic, I would like to start with discussing about respiratory failure. As you all know, the respiratory failure is a clinical condition which happens when there is a respiratory system fail to maintain their main function, that is gas exchange. There are two types of respiratory failure. One is type 1 respiratory failure, we also known as hypoxic respiratory failure. So what the problem is, there's a problem in oxygenation at the alveolar capillary membrane level. So when you do ABG, you can see arterial oxygen saturation is less than 60 with normal or subnormal carbon dioxide level. These are some examples of type 1 respiratory failure, which can occur in pneumonia and atelectasis due to shunting effect, and also can be seen in and pulmonary fibrosis due to diffusion limitation and alveolar hyperventilation. So how can we intervene in this situation? Air supply to the patient, that is FiO2, and also increase the mean airway pressure. So that will recruit the alveoli, that will improve the oxygenation, and that will fix the patient's problem. And the second type is type 2, inability to exchange their carbon dioxide due to the pump failure. So when you do the ABG in this patient, you can see increased carbon dioxide level with reduced pH. So these are some example for type 2 respiratory failure. This can occur due to central obstruction in CNS depression, upper airway obstruction, lower airway obstruction, or due to neuromuscular disorder. So how do we intervene in this situation? So we can either increase minute ventilation of this patient by increasing respiratory rate or tidal volume, or changing the dead space, or by changing the expiratory time. And I will start to in brief to epithelial type 2 epithelial cell and interstitial epithelial cell and vascular epithelial cell occur during viral infection, and which give rise to change in the lung. So this changes in lung occur in two phases. We call one is early phase, another one is late phase. In early phase, you can see the pulmonary vasculopathy of thrombosis, and late phase you can see widespread lung atelectasis, and that will give rise to non-aerated pulmonary units. So ultimately, the patient is going to the hypoxemic respiratory failure. That's the main problem in COVID patient, and also it associates with the systemic inflammation. You call it cytokine storm syndrome. So where you can see the elevated serum CRP and ferritin level and interleukin-6 level. So we can use those parameters to monitor the patient, severity of the patient, or this outcome of the patient. And finally, will provoke the DI systemic inflammation and direct viral epithelium. This is the natural history of and stage 2 where the pulmonary changes occur. So at this stage, patient can present with shortness of breath and or hypoxia. And when you go to the final stage, you can see the widespread respiratory, widespread inflammatory response of patient will end up with ARDS and SIRS, or shock. Okay, how we are going to manage we can divide in patient into three categories according to severity of disease: mild, moderate, and severe. So mild patient, we don't have to do anything; you just need to regularly monitor the patient. When it comes to the moderate to severe patient, that patient saturation is less than 93, but they don't show increased work of breathing. So you can start low for oxygen, as Dr. Dylan mentioned. What you can use either one of them. So you can go up to flow rate 50 minutes, and have to check the patient vitals regularly, whether the patient is going to deterioration. So when the patient come into the severe critical form, this is when the saturation less than 90 with the signs of work of breathing. So you have to select either high flow nasal oxygen cannula or CPAP or NIV devices. So we call it, they are the bridging therapy. So if you're going to start this bridging therapy at your hospital, you have to aware of the oxygen supply at your hospital, because as you know, if for example, if we start a high flow oxygen at 60 liters a minute, so that patient consume 12 jumbo cylinders per day. So there's a huge number of oxygen demand. So your hospital should have these facilities before you're going to start this treatment. So what is the best? With the hyphonase or CPAP? This HINUK. They recommend one non-invasive positive prayer ventilation when managing a hypoxic respiratory failure patient who not respond to the conventional oxygen therapy. Their data showed if we started high flow nasal oxygen cannula for these kind of patient, there's a reduction in intubation, and also 90-day mortality also reduced, and more ventilator-free days associated with that. And this is other international societies which recommend early use of hyphonasal oxygen cannula or other modality. WHO also recommend using hyphonasal cannula early, and Australia and New Zealand Society, Intensive Care Society also recommend hyphonasal oxygen cannula. Okay, what this is a hyphonasal cannula. It has several parts. You have to be aware about that. This is a flow meter. You can check the flow that you're giving to the patient. This is a oxygen air blender. You can adjust the FiO2 by turning here and there. And this is a heater. So it will heat the air to the body temperature when it passes. Going through it, you have to set the temperature, desired temperature, before giving to the patient. Usually we start with 34 and then gradually increase to 37 to the body temperature. And this bag containing sterile water that will help to humidify the air. And don't use a normal saline or distilled and dextrose to this one, because they recommend to use the sterile water. And this is a nasal cannula we attach to the patient. This is a common machine available. This one is available in Sri Lanka. Okay, what happened is hyphonasal nasal cannula. So it has a large bore when compared to the conventional nasal cannula. Because of that, you can give high flow to the patient, and it will supply heated and humidified air. Because of that, it will reduce the airway inflammation. If you send cold and dry air, that causes irritation to your nasal passage, and also reduce normal mucociliary function, and end up with a collection of mucus. So that part can be eliminated by using heated and humidified air. So also this machine, you can give fixed FiO2. You can start with the 21, you can go up to 100. And the advantage, because of the we can give high flow. You know, in normal maximum we can send is 15 liters per minute. But here we can go start with the 20 liters and go up to 60 liters per minute. That will match the patient ventilation demand, because when the patient is respiratory stress, he will take more inflated flow. So by giving a high flow, you can match it. And because of that, you can meet the patient minute ventilation. And also it wash out the patient dead space. You see in this diagram, this continuous air will wash out the air in this oropharynx and continuously replace this one, and that will help to reduce the dead space. Then this is oxygenated air in this area. And also because it will wash out the carbon dioxide, because it dilutes the carbon dioxide in this part, so that will give good amount of oxygenated air in this part, and that will improve the patient oxygenation. And other thing is it will because of the continuous flow, it if the patient mouth is closed, it will create a positive airway pressure in this passage, right? So it acts as PEEP, not like you can't generate up as in ventilator, but it can generate a small amount of PEEP, and it helps to keep your airway open. Some practical recommendation. So I will say that when you are going to select the nasal prong, so it should not totally occlude the patient nostril. Ideally, it should be a 2/3 of patient size of the patient nostril. And in Sri Lankan College of Anesthesiologists, in their guideline, they recommend start flow rate from 15 to 20 liters per minute in a COVID patient, and increase according to patient response. But some international guidelines say start with 30 to 40 liters per minute, and you can increase according to patient demand. And as I mentioned earlier, you have to set the patient temperature that will give comfort to the patient. And also you can increase the FiO2 until you get the satisfactory SpO2. And you can also deliver the flow when you see reduction in respiratory rate, and your saturation becomes stable. That means that patient is responding to your management. What are you going to monitor? So when you have put the patient on this high flow nasal cannula, you have to monitor patient respiratory rate, heart rate, and saturation initially more frequently. Then you can space it out depending on the patient situation. Once the patient becomes stable, and when you have decided now patient is stable, this patient no longer need high flow oxygenation cannula, so then you can wean off. So how we are going to wean off? So when we start with a reduction of FiO2 by 5 to 10% and reduce the flow rate by 5 liters a minute, and assess the patient clinical signs and symptom. And once the the machine's flow rate became less than 25 liters a minute and FiO2 less than 40, and when the patient is stable, you can take the machine off from the patient. So if there's no improvement to your treatment, you can escalate to the next level. In nutshell, this high flow nasal external cannula provide heated and humidified air. Also match the patient inspiratory demands by meeting up the patient peak inspiratory flow demand. Also increase the functional residual capacity by making a small PEEP and providing a continuous flow. It is lighter than when compared with other CPAP or BiPAP machine, and the main advantage is it will inhibit the oxidation dilution which can occur in other devices like other low flow oxygen devices, because of supplying continuous high flow, and is also helpful in washing out of dead space of the patient. So this is and when we go to the advantages of high flow nasal cannula, main advantage is low risk of aspiration, and it will reduce the need for intubation and no claustrophobia. If you're going to put a CPAP, the patient is scared of that because of the claustrophobia. What are the other indications than treating COVID pneumonia? Um, Mainly, these are the indications mainly due to hypoxic respiratory failure associated with community-acquired pneumonia, other viral pneumonia, acute asthma, or CO poisoning, carbon monoxide poisoning. And also you can use high flow nasal cannula to supply high FiO2 oxygenation in the situation when we are going to pre-oxygenation patient, anaptic oxygenation, and to prevent the post-intubation distress. And when we are managing patient who say no, we have decided not to do active resuscitation of this patient, then we can give the high flow nasal oxygenation as a palliative therapy. And also post cardiac surgery, and when some intervention like bronchial lavage, TOE, upper GI endoscopy to supply high flow. All right. When we discuss about evidence, there are a lot of evidence to support use of high flow nasal oxygen cannula in COVID pneumonic patient as a early treatment strategy. The one study done in China, they have found this higher survival rate in high flow patient with high flow nasal cannula than an non-invasive and invasive ventilation. Okay, and some says NNF is preferably better than BiPAP. All right, that's the end of high flow nasal cannulation, and then we'll move to non-invasive ventilation. What is this non-invasive ventilation? So non-invasive ventilation is application of respiratory support via interface. This interface could be either face mask, nasal cannula, or full face visor or helmet without need of intubation. There are two types of non-invasive ventilation. It's a positive pressure ventilation, or other one is negative generator to the chest, like this iron lung. Iron lung that will generate the negative pressure that will help the patient breathe in. But this is not commonly used nowadays because of very, it's very heavy and very bulky and difficult to use. Now we commonly use CPAP and BiPAP as a non-invasive positive pressure ventilation. This is a respiratory machine. It's very commonly used in emergency department and high dependency care unit. It's a small one compared with your conventional ventilator and easy to use, and I think it's cheaper than that. This is the interfaces that we use to deliver non-invasive positive pressure ventilator to the patient. We can use a nasal mask. Usually it's helpful in the patient with obstructive sleep apnea. And this is a full face mask. This is you call it a total face mask. This is the CPAP helmet. This on carries its own advantages and disadvantages. When we talk about this, I think it is not available in Sri Lanka. The main advantage is that it will prevent the environment contamination in COVID patient, and is also if the patient that will prevent aspiration if the patient have active emesis. This is the one we usually use in Sri Lanka, and the thing is you have to select the ideal size for the patient when you are going to fix this on the patient face. It should cover the bridge of nose and lower part of mouth. It should not be jutting out from the chin. So this because of that, if you use proper mask, that will prevent unnecessary leaking, and you can give it your target setup to the patient. And before starting this one, you have to explain the patient what are you going to do with, otherwise patient will become very anxious. That will not going to helpful and you are going to do it. Another thing is you have to keep this mask once you start the machine. You have to keep this mask on patient face without putting strap and allow patient to get used to this one. And after patient get used, and you can fix the straps. Okay. As I mentioned earlier, there are two modalities in non-invasive positive pressure ventilation. One is continuous positive pressure airway, another is BPAP, BiPAP. So what is this CPAP, also known as conventional ventilation. When you put the patient on CPAP machine, uh, it will give continuous positive pressure throughout patient's respiratory cycle. And you can apply if the patient is breathing spontaneously, because it does not give a respiratory support like BiPAP. So you can't use in patient with apnea and who is hyperventilating. So this CPAP is to fix the oxygenation failure, especially in patients with the type 1 uh, respiratory failure. In COVID patients also, most of them have type 1 respiratory failure, so you can use CPAP. So what happens? Because once you're giving a positive pressure ventilation, um, patients alveoli keep split open, uh, and that will prevent them collapsing during expiration. And also this will recruit the more alveoli that will increase the matching between ventilation perfusion, and that will finally increase the saturation, patient saturation. Also, it will also increase the mean airway pressure, by which you can increase the functional respiratory capacity of patient, and that will cause large amount of air at the alveolar level to the ventilator. So it is said the CPAP may be the best modality of NIV in COVID patient. How it become best modality? Because it does not augment the patient tidal volume. So that will facilitate more lung protective ventilation. And it also provides the greatest amount of alveolar pressure when compared with the BiPAP. So it was helpful in effective recruitment. So I will show in this paragraph what I mentioned earlier. So this graph show mean alveolar pressure in CPAP and BiPAP mode. This blue line is the mean alveolar pressure in a patient who has set to CPAP at 18 centimeter per water, and this dotted red line shows the mean alveolar pressure when you set the BiPAP at 18 to 18 over 6. So you can see this be in CPAP, the mean alveolar pressure is greater than mean alveolar pressure in BiPAP in that setup. So that means the so CPAP machine can, if somebody put on CPAP machine, can recruit the more alveoli than the BiPAP machine. And in COVID patient, you see, you know that there is a widespread microatelectasis in lungs. So when you are using CPAP, you can open up this alveoli because it's providing the greatest mean alveolar pressure. Okay, how are I going to set up the patient? Once you attach the patient to the machine, so your target would be a normal patient, I mean, not seriously ill patient, target would be to increase your saturation more than 94. And if it is more ill patient, then you are going to keep your target between 88 to 92. Here we usually we start the P value of 5 and then gradually increase to 15. But in the COVID patient, they said have to start from 7 and then gradually increase to 50 to 8. So while you are increasing the PEEP, you can check the patient saturation, arterial saturation, respiratory effort, and hemodynamics. These are the things we have to monitor once we have started the PEEP patient, whether patient, usually after 30 minutes to 1 hour, you can check whether the patient is going to, patient condition is going to improve or further deteriorate. You have to check the saturation, you have to check the work of breathing, you have to check the level of conscious, and also you have to check the hemodynamics, and you have to do the ABG and analyze the blood gas. And sometimes patient can deteriorate due to development of new complication like pneumothorax and sputum retention. This is a diagram. These two graphs will show the intraalveolar pressure during both in unassisted breathing and patient who have on CPAP. You can see continuous positive airway pressure during throughout the breathing. Okay, let's move to the BiPAP mode. BiPAP is merely for the patient with type 2 respiratory failure. That means there's a problem is ventilation. In a COVID patient, you can use if they have concomitant COPD, or if they are seeing in their blood gas carbon dioxide retention, then you can switch to the BiPAP mode. So whole mark of this BiPAP mode is there are two set of pressure support we are giving to the patient. One is EPAP, that's called CPAP, and IPAP. This IPAP, when the machine give IPAP when the patient start to breathe. Their space cycle machine give IPAP. The most important thing is the difference between IPAP and EPAP. You call this pressure support in your conventional ventilator. This pressure support is important to increase the tidal volume. That tidal volume ultimately reduce the patient carbon dioxide level. So if you want to eliminate carbon dioxide, so the thing is you have to increase the IPAP. If you want to increase oxygenation of this patient, you have to elevate EPAP. This is BPAP and also called ST mode. And this is what I mentioned earlier. So you have that one also. You have to start with 5 to EPAP start from 5, and you can go up to 15. And IPAP you can start from the 10 and you can go up to 20. In COVID patient, you may have to give 17 or by 12 to get a good outcome. This is as in CPAP mode. When you're patient in the BiPAP mode, you have to monitor the patient's saturation, work of breathing, and arterial blood gas and hemodynamics, and ultimately check whether the patient is improving or deteriorating. If the patient is not improving with your changes, and then you have to escalate patient to the other level of care, that is intubation. So as I mentioned earlier, if the patient remains pressure respiration remain more than 20 minutes or carbon dioxide more than 45, that means this alveoli is not ventilating. So you have to increase the IPAP by 2 centimeter for the increment. If the saturation remains 88, you can try with increasing EPAP. If patients still remain carbon dioxide PaCO2 remain high, then you have to check whether you have selected proper FiO2, especially in the patient with the COPD. So that we have to reduce FiO2 in that case patient, or if there is excessive leaking from the mask. So if there is ongoing deterioration, you have to consider intubation and mechanical ventilation. These are the advantages of non-invasive ventilation in general. So these are the, because it will reduce the mortality and it will reduction the ICU days, and also reduction the deep airway infection like ventilated associated pneumonia occurring ventilation patient, and also prevent the intubation injuries. And possibly some, if you put in a nasal mask, patient can communicate. Risk is this non-invasive ventilation is it will cause misapplication and inefficiency can lead to respiratory failure. There's a high risk of aspiration, especially if you use high value of pressure. If you set the patient to your peak value to above the 10, there's a risk of aspiration. And it will also cause a dry up of your airway and cause a necrosis to the site where the mask um, fitting on. What are the contraindications use your non-invasive ventilator? You can categorize in according to anatomical, physiological, and human factor. So anatomical means if the patient has recent upper airway GI surgery, we do not use, or maxillofacial injury, surgery, or base of skull fracture or airway obstruction. And physiology, we do not use if the patients have active cardiac or respiratory arrest. And other thing is if the patient not able to protect his airway, that is poor cough and decreased level of conscious state. And also for the patient with untreated pneumothorax, we are not going to use this mode. And intractable vomiting. Human factor, when it comes to human factor, you don't use the patient. If patient refuses, not especially in palliative care, if the patient refuses, you're not going to put it. And if there is any aggressive or agitated patient, it's very difficult to use this one. And staff inexperience. What are the complications? Complication in general, so when we're using this tight fitting mask, it can cause pressure ulcer or necrosis, especially around the nasal bridge in elderly people. And it also can cause a facial and ocular abrasion, and it causes eye irritation, loose fitting mask, because there's a air leakage from this mask and going into the eye and cause ocular irritation. And the claustrophobia and agitation, and also that can cause hypotension in a patient who is already hypovolemic. And there's increased risk of aspiration, and it will increase the risk of increase your intracranial pressure and intraocular pressure. And because of if you put the patient on mask, it's difficult to give foods for this patient. This is my last slide. That will this summary of overall management of COVID patient. So we'll start with low flow nasal cannula, and then if patient need deteriorate, we have to escalate it into the high flow nasal cannula or CPAP mode. Now we know most of them recommend to use high flow nasal cannula as initial management because there are a lot of advantages. And if this one is not, you can interchange this line, because especially during the daytime you can keep the patient high flow nasal cannula, and the night time you can put on the CPAP, because when the patient with the high flow nasal cannula, you can do wake proning of the patient. And if still failing, so then you can go to the invasive mechanical ventilation. Ultimately, patient will end up with the ECMO. That's conclude my lecture. Do you have any question?
So in chat box, there are 2 questions.
What is mean by bridging therapy? So bridging therapy is like if the therapy between your conventional oxygenation and ventilation, intubation and ventilation. So we use this either high flow nasal cannula and non-invasive ventilation as a bridging therapy that will prevent the patient further deteriorating. What is the next question? Please explain effectiveness. Can we have this? Yes, we have. Can we go for NG feeds who are in high flow ventilation? No, actually, I don't think we can give NG feeding when the patient is on high flow nasal, because that will prevent giving high flow nasal, because you have to have a good fitted nasal prong to give high flow nasal cannula. In that case, you can have other mode of feeding. Any difference is single limb CPAP and dual limb CPAP. The only I don't see any difference. The only thing is dual limb. That means there's a very expiratory uh, expiratory limb, so that will prevent uh, your environment contamination with the infection. I think that's the only advantage I can say at this moment. How long can we keep the patient in high flow oxygen? That is depend on the patient clinical outcome. If the patient is deteriorating, you can't do it. But if the patient getting comfortable, getting improving, so you can start weaning off.
I think Bhaginder, so they're asking about the effectiveness of oxygen concentrator machine for providing oxygen in high flow therapy. So oxygen concentrations usually don't give high flow. So they give usually 5 liters per minute, but there are some modern versions which gives about 10 liters per minute. So you can't use for high flow oxygen therapy unless you convert with the use of some of the high flow device, whether you convert it or you can't. Just oxygen concentrator, no high flow.
Okay.
And regarding this ResMed CPAP machine, so the older version does not have FiO2 sensor, so you can't check it. So you have to go clinically and from the flow rate. And there are some newer version which have FiO2 sensor and FiO2 read as well. So you can, so it depends on the model. So you can go through the model leaflet booklet, and if it doesn't say anything about FiO2 monitoring, that means you can't.
Someone is asked COVID heart failure, CPAP or BiPAP, what is better? In my recommendation is CPAP is better because CPAP it will improve the cardiac output by changing the transmural pressure of the patient, and it eventually reduce both preload and afterload. That will help in increase patient cardiac output. And other thing is CPAP machine can help helping get rid of this alveoli which has already accumulated filled with the water.
The question about the FiO2, Bhaginder, like as Chamara said that we have only ResMed 100. If it is 150 or 200, then only we can measure the FiO2. Otherwise, we can have a rough idea about oxygen. Basically, we give about 15 liters of oxygen, and just according to the, according to the flow, only we can increase the FiO2, but only rough idea, but not the accurate idea. When you have a ResMed 150 or 200, then yes, you can measure FiO2.
Right. Okay, thank you very much. And next lecture will be done by Dr. Berubadarachi.
Excuse me, sir, one more question. What are the changes applying HFNC when using for pediatric patients?
What that question? What's that question? What are the changes apply high flow nasal in pediatric patient? Okay, in the pediatric patient, the only thing is there are specific high flow nasal devices. You can't use adult one. And other thing is you have to use the pediatric cannula, nasal cannula for that patient. And usually you can go up to 2 liter per kg. That is the maximum level you can use. And if that you can start with 1 liter per minute per kg, the flow rate. And if the patient deteriorating, then you have to go to the maximum 2 liter per kg per minute. If patient is further deteriorating, then you have to select intubation or do something else. then that means that high flow nasal extension will not going to work for that patient anymore.
Seems there are no questions. I would like to thank Dr. Bhaginda Gunawardana for his excellent presentation on behalf of the GMOA COVID Coordination Center and GMO Sri Knowledge Academy.